operator. I would say here, Simon's got to be very careful to make sure he chases that bone right up and over the horizontal shelf of the turbinate, because that's one of the biggest things I see happen in people who do turbinate surgery is that they leave the horizontal shelf and just take the vertical strut of the turbinate bone. When in fact, you know, and I'm sure Simon will tell you, it's the whole purpose of medial flap turbinoplasty is to get the turbinate to sit in a more lateral position.
So this is what Richard's talking about here. You see, as it's going up and over here, this is the bit that is often forgotten.
And I just saw you operating there, Simon. You didn't tell the audience, but you'd done the under-over technique, you know, where you'd flipped your instrument and endoscope, which is quite technically challenging, but you just naturally were doing it. And when you're suddenly in that position, you're sort of not really seeing the upper part of the turbinate bone. So thanks for pointing it out.
No, it's amazing how we do things subconsciously without thinking about it. Okay, so can I get Turby scissors, please? So the last thing I want is to pull down on here and then rip this whole flap. So what I'm actually going to do here is actually do the next best thing, which is actually just where the bone is freed up. I'm just going to cut it. And then try and show you these vessels. Let's get straight Blakes, please. The other thing that you can do, I know it's interesting, Richard, I don't know, Richard sees far more complicated patients than I do. But I mean, I've had several patients over the years, like teenagers with von Willebrands with massive turbinates and problems. And I've actually used, you know, you can actually use the coblator to essentially have a completely bloodless turbinate. And it's something, it takes longer and it's more technically challenging, but it's a bloodless way of dealing with patients with, you know, with serious risks of post-operative problems if they bleed. Okay.
When you use a collaborator, you may collaborate the lateral mucosa, right?
So use the use I think we use the Easy View, the nasal coblation wand, or even an EVAC 70, the tonsil wand, you know, where you're actually doing the same technique that you're seeing me now, but with a coblator rather than a microbrider. I was thinking about demonstrating it, but then I thought, you know, that would have changed my normal clinical practice, which I didn't want to do. Okie doke. So let's go and see what's happening with the rest before we. Okay, so let's take away, can I get the suction freers again? And we'll take away this horizontal plate here. And the important thing about this technique is to make sure you identify the blood vessel at the back and deal with it. Don't just presume it's going to be all right, because invariably it won't. And then you'll end up with a bleed. Maybe not tonight, but maybe in a few days' time. Okay, can I get some straight Blakes, please? Thank you. There we go. That's what we want out. All right. So suction freers. There we go. There you can see the neurovascular pedicle coming in at the back. What we'll do is we'll make sure we deal with that before we call this a day. But I want to deal with this last bit of that horizontal part as well. Normal freeze, thanks, Bree. Straight legs, please.
Hi, Richard. How are you? It's Dishapong. Professor Harvey. Okay, he's not here.
Okay.
I think Richard forgot
Yes,
you
please.
already.
He's gone off for a coffee, as he corn cat.
So that is a posterior nasal nerve. Huh?
Yeah. So I think what we'll do is I'm not going to cut it. I'm just going to use bipolar and to basically get the vessel as well as the nerve. And I'm going to take away that shelf there. You can see the blood vessel coming along there nicely. So straight legs, please. You've got to remember, the further you go back in the turbinate, the more this blood vessel goes into the bone. And so the more bleeding you get, because it actually enters the turbinate through a bony canal. Suction free ears, please. All right, I'm just going to get rid of this last bit of bone first. So we're just leading with mucosa. Turbinectomy scissors, please. And, you know, certainly in the UK where I trained, nobody did turbinate surgery like this. It was all just with scissors, and you just chopped it off and hoped for the best. And it really wasn't very satisfactory from a esoteric point of view. Never mind what the patients got as a result afterwards. And certainly in Australia, and I know Thailand's a bit more humid, corn cat, but certainly in Australia, we don't get away with radical turbinectomies here because patients get dry, crusty noses. I'm not saying they get empty nose syndrome, because I know Ray Sachs has done a lot of work on that. And it, you know, the jury is obviously still out as to whether or not empty nose syndrome, you know, really exists as a specific syndrome.
Yeah, it's good that you mentioned it, because it's a big concern of all of us. And I think many people, when you look at your surgery, they will say that it's quite extensive. You remove a lot of bone work and also the lateral mucosa. But But I know you and I and Richard, we never have any cases of Etinel syndrome because it's not about the volume of the turbinate we remove. What do you think, Simon?
Sorry, I can't hear.
Sorry. I mean, most people are concerned about empty nose syndrome, especially when we remove the turbinate bone, we remove the lateral mucosa of the inferior turbinate. And
The vast majority of this lateral mucosa is intact. This is, you know, we've preserved all this mucosa. This patient is not going to get empty nose syndrome. Prius, please.
Yeah, you're right. So we preserve the mucosa very well, so the patient can have normal physiology.
So I don't know if people can hear Kim better than me, but I can't really hear. Yeah. Yeah. Can I get it straight, Blakes, please? See, I don't regard this as a radical turbinate operation at all, Concat. This is more a conservative one. I think what's far more radical is the quick chop. Turbinectomy scissors, please. Okay, so there again, you can see a blood vessel in that last bit. Suction by, please. And if I were just to pull this out, this would bleed like crazy.
Yeah.
See it there?
It comes through the bony tunnel.
Yep, and this is as we've dissected down that last bit of bone. You can see the blood vessel there beautifully. I'm just going to pull that. There we go. There we go. Got it.
It may not be.
All right. So straight legs, please.
It may bleed in the recovery room if you do not manage it effectively, right?
Yep. Then microdebrider, please. Okay, freeze, please. Can I get a strip of Surgicel, please? Surgicel, thanks. So we're going to roll that over, put a little strip of Surgicel in there. Do you use Surgicel, Concat? Or do you just leave it? Freeze, please. Concat, you there?
Yeah, I'm here.
Do you use Surgicel? Do you use Surgicel Fibrilla, or do you just leave it?
I use
Leave it.
Surgicels. I use Surgicels, yeah, like what you do.
If it sits nicely, sometimes I don't bother. Okay, can I get a stitch, please? So we're now going to just close this septum by doing a darn, and then probably call it a day. Do a little bit on that left side turbinate, but it's not. I'm not going to do a lot on that on the right side. Sorry. So you want to pull this flap forward before you put that first incision in. And this is a 4-0 vicral repeat, is it? Normal vicral. What I'm going to try and do is just bring this one forward so it's just sitting in front of that incision so that we can close that flap with as little crusting as possible. There we go, if I can give you that one. Clip, please. Got it. So I put a little clip on that bit so it doesn't get caught up as we're trying to do the darn. The important thing is that area where we had that little bit of, a mucosal tear right over the apex of that spur. We really want to make sure that's as close as possible. But you see, it actually looks quite good. The other advantage of doing the darn is to prevent septal hematoma, which I don't know about you, but is fortunately a thing of the past, I think, with modern techniques. I don't know when you last had a septal hematoma either of Richard or Corncat, but I think they're very uncommon. And then the important thing is to get under this flap. So this next one is really critical. What you want to do is go to the back and then come under this flap here and try and elevate this up. So that closes. I don't think there's going to be a problem anyway. I don't think it's, a big issue, that slight tear. But let's go and have a look.
I would prefer
so look at that. That looks really nice now.
I would prefer to have a drainage hole. So like you say, it's not a problem that have.
Yeah, I agree. I don't think it's a problem.
Simon, you mentioned about floppy septum.
Yep.
Is it common in Australia?
I've never had it. I mean, it's very popular to talk about it here because there was one ENT surgeon who had an old style SMR himself who said that he was very aware of a floppy septum. And so this myth of the floppy septum has sort of been, I think, exaggerated as to its prevalence. I think a lot of problems with septal surgery are for not taking enough out, leaving too much behind, and not addressing the maxillary crest. People seem very scared to chisel off, big bony spurs inferiorly. And I think that's where a lot of septal surgery fails. And so there we go. That's my darn. Iron looks quite nice. I'm quite happy with that. Now, can I just, we talked about out fracture. I think I'm just going to out fracture this one. Straight Blakes, please. Because, sorry, Frias, please. Okay, and then straight Blakesley's, and then nasopore. So those turbinates are sitting nicely. Sometimes if I'm worried, I will bulgerize the turbinates and sort of try and get them to stick to the septum. But because we've done so little, I don't think there's a lot of a problem here. And I'm going to use some bioabsorbable dressing. We're using nasopore here with Kenacort triamcinolone on it. And that's just, I'll remove this. Now, when I put this in, I always have a little bit coming forward because this is where the adhesion is going to happen. You also want to make sure that maxillary ostium is open and you're not blocking that drainage pathway. So I want that high enough that it's not going to come down and cause a problem. And if it is, then you rethink the position of it. I think that, let's go out the way. Come on, I don't want that flopping down. That's looking better. Okay, next one. What do you use, Corn Cat? I know Richard likes his finger, rubber glove.
Yeah.
Fingers.
Yeah, I'd like to say, I do not do modularization in all cases. If the middle turbinate is not floppy, I will support the middle turbinate. But in the past years, I used like Richard did, but not nowadays. Now I use the same thing that you are doing, not support.
Freeze, please. Have I got it? No, I've got the scissors. You got it? All right.
But if the middle turbinate is floppy, especially in the deviation side, we should manage it properly. We may do modularization. We may even resect the middle turbinate.
Sometimes I'll include it in my darn, Corn Cat, especially if I've got a big concha bullosa. I'll actually suture it to the septum. Okay, I've got that. I'm going to sucker first. So what I'm... So what's this called again? Puristat. So when we've got a tear here, something that I've been using recently, and I used to use it on the turbinates as well, but I've gone off using it in the turbinates because I'm a little bit worried, is a thing called Puristat. I don't know if you've used it. Basically, it's a hemostatic gel, and people have tried it on, Freeze, please. They've tried it on tonsil wounds and all sorts of things. There's quite a bit in the ENT literature on it. And just to, so it's almost like a sealant that I've just put over that. And just look, that just sits very nicely. All right, and that's just going to add that extra bit of barrier to stop it bleeding. Okay, so we're going to switch off now. You guys can do a Q&A. I will try and come on once the patient's off the table. So we offline, Kim?
Thank you, Simon. Before the Q&A session, I would like to give a brief introduction of the APOST. Bonnie, can you share your slide?
Yeah, sure. Wait a second.
And I would like to say welcome again to everybody who joined the live surgery today. It is the APOST Basic FESS course, live surgery, demonstrated by Professor Simon Carney from Australia. We have today Professor Simon Carney. He will demonstrate 2 live surgeries, followed by a lecture by Professor Richard Harvey, and then we'll finish after my session, my talk. APOST stand for, go back, Asia Pacific something, Otolaryngologic Surgical Training Group. So it's a surgical training group. We would like to promote the training, and it was established for education of otorhinolaryngologic surgery in Hong Kong and also in Asia Pacific region. And we have a regular meeting with the board members to develop the strategies. We make the action plan and we make training programs every year. Not only for senate surgery, not only for FESS today, but also for all kinds of otorhinolaryngologic surgeries in Asia Pacific region. And we would like to provide the comprehensive programs with practical follows. We will not talk a lot about research. We may mention about our studies to support why we do this. But we would like to give you the practical point and tips and pearls in surgeries. And we would like to work with any society, association, or person for the purpose of developing education training. So, for example, we work with Flinders universities, University of New South Wales, Macquarie University, and Chulalongkorn University for today. And we have Professor Michael Tong. He's from the Chinese University of Hong Kong as a chairman. And we have Professor Simon Carney is a vice chair and treasurer. Dr. Jason Chan from the Chinese University of Hong Kong is our secretary general. And we have 5 board members from 5 countries. Liang Junlin from Singapore, Taro Sugimoto from Japan, Richard Harvey from Australia, Prepar from Malaysia, and myself from Thailand. So we started our training program with the lecture, dissection demo, and supervised hand-on dissection. But because of the COVID-19 pandemic, we have a new normal of the surgical training. We have online training like today. And then if you visit our website, you will see the platform of e-learning that you can look at our videos, the interesting cases, and very good lectures. And today is a post basic FESS. So when you see basic FESS, it means that we care about all kind of junior ENT and also the senior ENT. So we will have advanced FESS as well. Move, please. Okay, I have mentioned about programs already. Okay. And for the next week, we will have the APOST Basic Ear Surgical Skill Training. So it's a free registration. Please sign up. We will have Alexander Saxby. We have Barry Tan and Moon In Sok from Korea. The agenda is about otology, operation, preparation, and precaution, and tips and pearls for mastoidectomy and cholesteatoma surgeries, and also basic procedures for meninoplasty and osculoplasty. Okay, so please visit our website and for further contact. Now we have a lot of questions. Simon, are you with us? Okay, Simon is gone. Huh? He's preparing the second case, maybe. The first question is for cartilaginous septal spur. Do you prefer to start with inferior conchotomy and then posterior chondrotomy? How about if there is only bony septal spur? Do you prefer posterior chondrotomy first? Thank you. Richard, are you with us? It seems like I am alone. So as Simon says before, we do not provide same surgery to all patients. You need to assess the septal deviation of your patient. If it is cartilaginous septal problem, is it a bone problem? Is it affect the nasal valve? Does it affect the nasal resistance, or does it affect the osteometal complex? So if the cartilage, the septal cartilage is good, I will not touch the cartilage. I just manage the bony spur. I just manage the maxillary crest. But if there's both the cartilaginous septum problems and bony septum problems, I will start with the cartilage. I will raise the anterior tunnel, and then we go to posterior tunnel doing the bony work. And then after we are done with the bony work, we will manage the septal cartilage. Okay, so the next question is how many bits should be taken to ensure not to traumatize nasolacrimal duct? So if you watch Professor Simon Carney demonstration carefully, you see that he never touched the nasolacrimal duct, and he never even get it close to nasolacrimal duct. Because what we manage is the inferior turbinate. Professor Simon Carney preserved most of the mucosa. He mentioned that it is meticulous surgeries. So the nasolacrimal duct is located at the lateral wall of the nasal cavities. We will not use the instrument to damage that mucosa, just the mucosa of the inferior turbinate. Actually, there's a variety of the technique to perform the inferior terminoplasties, but all techniques do not touch the nasolacrimal duct or will not touch the mucosa of the lateral nasal walls. Okay, so we move to the next question. In the middle meatal antrostomy, should we remove posterior frontanel? I think there are two schools of thought, and also it's up to the aim of your sinus surgeries. For the middle meatal antrostomies, we may do it for the ventilation and drainage. And when you do for the ventilation and drainage, there's a school of thought that we should preserve the mucosa as much as possible. We should not touch the ostium if it's not necessary. That is one school of thought. And then the other school of thought is we want the good therapeutic outcome in the long term. We would like to maintain the middle meatal antrostomy in the long term. And so many chronic rhinosinusitis, it's not about ventilation and drainage. We would prefer to have a long-term care, and the patient can have self-care with nasal irrigation. So if you would like a topical management of the microsinus in the long term, I think you should remove the posterior fontanelles and maximize the middle meatal antrostomies. But if you ask yourself and you say your aim is just to manage the ventilation, for examples, the patient have pressure effect when they fly, and and then they don't need to rinse their nose in the long term. You may not touch the posterior fontanelle. But for my practice, and I'm sure for Richard, how we practice, and Simon, we maximize the antrostomies, and then it means that we need to remove the posterior fontanelle. Simon and Richard, if you're with us, you can share your idea anytime. The next question is, do you agree that removal of the horizontal part of the uncinate process should be before removal the posterior fontanelle as end step of the MMA or middle meatal antrostomy? I think, as I mentioned before, there's a variety of surgical techniques. It's not a kind of right or wrong. You may do this step first, you may do this step later, but actually, for sure, you need to manage the upper part of the uncinate process. Otherwise, you cannot see the maxillary sinus ostium because it's hidden in the anterior fontanelle. So, but the question is for the question asks about removal of the horizontal part, which means the inferior part of the uncinate process, right? So like Simon just demonstrated that he removed the bone submucosally of the inferior part of the uncinate process without removing the mucosa of the inferior part of the uncinate process. So for in this case, he may manage the posterior fontanelles. So my answer is, it's not right or wrong. You may do this step first. You may do this step at the end step. But for sure, you need to manage the upper uncinate process first. Regarding the concha bullosa, why you prefer to use microdebrider to endoscopic knife? I think, once again, there are a variety of surgical technique. It doesn't mean much about cold knife or microdebrider. There are many tools that you can use. But one thing that Simon Carney shows us is the meticulous surgeries. And he very careful not to leave any bone spicules in the surgical field. So at the end, there's only mucosa wound, right? And then the two edges of the mucosa will meet together. Huh? So it heals perfectly. It doesn't matter you use microdebrider, it doesn't matter you use cold knife. I think it's not the important issue. And then, doctor, you're removing entire inferior bony concha, is it? So what is the aim of the concha bullosa surgeries? We would like to remove the whole pneumatization of the middle turbinate because there are two things. It pushing the nasal septum to the other side. So if we do not remove the entire pneumatized bone cell of the middle turbinate, we may not manage the deviated nasal septum properly. And the other thing is it may compromise the osteometal complex of the right side. So once again, we need to remove the whole air cell of the middle turbinate. And then our aim not only to remove the whole concha bullosa, we would like the mucosa within the concha bullosa to meet normal mucosa of the nasal cavity nearby. The next question is, would you suggest to diatomize the posterior artery before removing the posterior part of the inferior concha to avoid risk of bleeding? Actually, Professor Simon Carney has mentioned that the inferior turbinate artery come through the bony tunnel. So when it comes through the bony tunnel, you need to remove the bone. Otherwise, you cannot diatomize effectively. Uh, you you don't need to worry much about the intraoperative breathing because you give decongestant, effective decongestant. It does not breathe intraoperatively. If it breathes, it will breathe in the recovery room. So if you don't want the patient to breathe in the recovery room, you should diatomize effectively by removing the whole bone of the inferior turbinate. So you can see the inferior turbinate artery clearly. And then after you see it clearly, you can manage it effectively and use the bipolar cauterization. May I know what is the mean arterial pressure and heart rate during these surgeries? Actually, Simon Kani need to answer this question, but I am sure the mean arterial pressure is just perfect by the quality of the surgical field, and the heart rate should be good. When we say the heart rate is good, we would like the heart rate of the patient to be around 60 beats per minute. But from my experience, if the heart rate go up a little to 70, the surgical field is still perfect. But if the 80 and 90 is not too bad, but it's not excellent. But we can still operate the patient with the heart rate of 80 and 90. But if it goes up to 100, the surgical field will not be very good. So we should coordinate with the anesthetist to low down the heart rate. Is there extra benefit to close the septal flap incision by going through cartilage versus just a simple interrupted suture at the mucosa flap incisions? Very good question. Professor Simon Kani mentioned that when you do the suturing, you can prevent the patient from the complication of septal hematoma. So if you just close the incisions, you do not prevent the septal hematoma. There is a potential space along the bony cartilage and the septal cartilage, and the septal bone. So you should run your suture from anterior to posterior and from posterior back to anterior to prevent the septal hematoma. And then you notice that Professor Simon Kani also tried to close his the wound inferiorly when he removed the bone spur and there's a mucosal tear. And the next question is, when would you do the first nasal toilet after surgery? Is it the next day? Would you remove the surgical next pack during the first nasal toilet? Actually, we will let the patient rinse the nose on the first day after surgeries. So if the surgery is day 0, we will let the patient rinse the nose on day 1. So the first nasal toilet after surgery should be one day, the following day. For the surgical, we leave it there. After 1 week, we may clean the nose. Would you use silastic sheet during septoplasty to secure the breathing? So I think there are 2 things in this question. One thing is silastic sheet. The other thing is the breathing. I think Richard Harvey and Simon and a lot of experts use silastic sheet, but not to prevent the bleeding. But when you put in the silastic sheet, it will protect your wound. It will protect your septal mucosa from the damage by the airflow. And when you protect it from the damage by the airflow, there will be less crusting. The mucosa can heal perfectly. after you remove the silastic sheet. And some silastic sheet has the airway, so the patient can breathe better through the silastic sheet with the tube, giving the nasal airway. But I don't think the silastic sheet is put in to secure the breathing, because we do the suturing to prevent the bleeding already. And what type of nasal irrigation would you want? Would you still perform the good? Oh no, sorry. What type of nasal irrigation would you suggest in this case post-surgery? Is it hypotonic, isotonic, or hypertonic, and why? We did one systematic review and meta-analysis to prove this and to answer these questions. One thing is we do not recommend hypotonic saline, but both isotonic and hypertonic saline give benefit to the patient. For hypertonic saline, they provide more benefit and together with the more harm. So I think in regular cases, I will give isotonic saline because it brings benefit. The patient can rinse their nose, can clean the nose, the wound can heal effectively with saline irrigation, and it promotes mucociliary functions. And then there's no harm, the patient is not irritating. But if you give hypertonic saline up to 5%, the more concentration, the more irritating, but the irritation is tolerable. It's not too bad, but compared to isotonic, it's more irritating. But if you assess the effect of hypertonic saline for allergic rhinitis, for chronic rhinosinusitis, they bring more benefit significantly. So I just preserve the hypotonic saline for complicated cases that isotonic saline did not give enough benefit. I would think of hypertonic saline. So in this case, I guess Simon would give just isotonic saline, but we find side effect of hypotonic saline, and we do not recommend that. If there is no tear in the septal mucosa, would you still perform the quilting suture at the mid and posterior part of nasal septums? So as I mentioned before, I think the aim of the suturing is to prevent the patient from the complication of septal hematoma and to close the potential space. So although there's no tear, we still do the suture. And as I mentioned before, actually, I would like to have the drainage hole. And then if there's some oozings, it can drain through the drainage hole that we create. Can we use silastic sheet at the end of septoplasty, but the posterior end of the sheet reach the middle meatus to decrease the chance of adhesions? I see many rhinologists do this. They put in the silastic sheet, and the posterior part of the sheet go to middle meatus. But for this case, Simon has put in the nasopore in the middle meatus to support the middle turbinate, that it will sit perfectly, sit nicely against the nasal septum. So he doesn't need to put in the silastic sheet into the middle meatus. But I do not see any problem if you put in silastic sheet and the end of the sheet go to middle meatus. And after you move the sheet, I think the middle turbinate will sit nicely at the nasal septum medially. How long would you keep internal nasal splint after septoterminoplasty surgeries? So I think there's a variety of the duration of the internal nasal splint that you put in, but actually it's about during 3 to 7 days. I think if you answer this question, you must ask yourself, what is the aim of the nasal splint? To me, I will put in the Silas sheet to prevent the nasal mucosa, the septal mucosa from the damage of the airflow. So I will let it heal, and then after that, I will remove the silastic sheet. What is the interval you suggest for nasal toilet and nasal endoscopy after septal terminoplasties?
Hi,
Actually,
I'm back online.
yeah, Simon, the question is, what is the interval you suggest for nasal toilet and nasal endoscopy after septoturbinoplasty?
I think, like you said before, it depends what you've done. I think if you've done a relatively conservative procedure and there's nothing that needs removing, you can extend the follow-up period of time. My standard default is about 10 days. But I say to the patients, if they've got a lot of crusting or a lot of blood clot they feel is there, that to bring that forward. I think the disadvantage of seeing them sooner is it's more tender. The advantages of later is you can do more, and you've got to find that balance. I think about 10 days is good. Sometimes patients will come back about 7 wanting a clean out.
Yeah, thank you, Simon. I think the second case is a full house FESS. So you will answer this question again about the interval you suggest for nasal toilet for the second case and nasal endoscopy, right? Because the crusting will be different between these two cases. The next question is, what is the extra advantage of performing turbinoplasty versus the radiofrequency inferior turbinate?
It's much a bigger effect and it lasts longer. I think you've worked with Ray Sachs in Sydney Concat, and his research, which has shown that really the turbinoplasty is the only method that has shown to have persisting benefit beyond two to 3 years. I think the evidence out there is that the turbinoplasty will give benefit 5, 10, maybe even longer, because you are physically taking the bone out and resculpturing the turbinate.
Yeah, right. And also you can manage the nerve when you perform turbinoplasties, and the effect will last longer, right?
Yeah, I think the
Thank
advantage is
you.
also it just takes longer, and that's why people don't like it.
Thank you for the demo. What is your pre-operative preparation, anesthesia induction and maintenance, and measures taken to reduce intraoperative bleeding, please?
Well, what I'll hopefully do is we'll get the anaesthetist to comment on that during the next case. I'll get Alistair to, tell us exactly what he's using. We don't routinely sedate the patients. We'll usually use an intravenous induction, and we use remifentanil, and we used to use sevoflurane, but now we've gone to desflurane just because of the recent evidence showing that desflurane and remifentanil is probably as good as Tiva. We try not to, the inconvenience of using Tiva with the risks of awake anesthesia and needing a BIS monitor, so we found that using the desflurane and the remifentanil to be fantastic. I used cocaine and adrenaline. I used 3 mils of 10% normally, but 10% we can't get anymore. So we're using 6 mils of 5%, 1 mil of 1 in 100,000 adrenaline, made up to 10 mils with saline. And we probably use about a third of that on the prep, and the rest goes on the scrub trolley. And then we use lignocaine with 1 in 80,000 adrenaline infiltration, and you should see me using the infiltration on the second case. I know the first case, it was already done before you guys came online in the interest of time.
Yeah, thank you, Simon. Actually, there are 20 questions and more are coming. May I ask Bonnie, what time shall we start the second case? Simon, are you ready for the second case?
The patient's got a bit of a migraine, so they're only just going, into the operating theater. So we may have another 10 or 15 minutes.
Okay. The next question is, what is the difference between MMA, wide MMA, and extended MMA? I think MMA is a middle meatal antrostomy.
Yeah,
So
normally for a mini FESS, if there's no accessory ostia into the maxillary sinus, we would just not remove any mucosa and just try and just fracture that bit of the horizontal portion of the uncinate and then leave it at that. When we divide the posterior fontanelle, that's what I would call like a medium-sized MMA. And I think in this next case, we'll demonstrate what I would regard a large ostium middle meatal antrostomy, where we'll take off that sort of buttress between the posterior wall of the maxilla and the posterior ethmoid, which is something that Richard, I'm sure, will comment on because it's one of his trademark techniques. So we'll be able to demonstrate that using the kerosene in the next video. And I think you need to work out what you're trying to achieve. And I mean, Concat, you mentioned that earlier on. If you've got a patient with eosinophilic disease, I think the general message out there is that because of the phenotyping and endotyping, you need maximal access into that maxillary sinus, and anything less than that will produce less good of an outcome. So, I think this idea of maximum FESS, taking down everything in the frontal recess, taking down everything posterior to the natural ostium into the posterior ethmoid, is the way to go for patients with eosinophilic disease.
yeah, thank you. Simon, would you stitch off the vicryl sutures and when?
Sorry, would you stitch off
your suture?
No.
And when will you stitch off?
Sometimes if it dissolves prematurely and they've got a straggling end in the nose, we would just divide that if the patient's got a problem, but I don't routinely remove the sutures.
Yeah. When we said MMA, what actually it includes? Does the MMA include uncinectomy and bulla ethmoidectomy, or the MMA term is just means widening the maxillary sinus ostium?
So the
terminology.
You've got to do the uncinate to get to the natural ostium. You can't get to the natural ostium without doing the uncinectomy, so you've got to do that. I don't always take the bulla down if I don't need to. The bulla, if you've got an intact bulla with a normal microbiome that's not getting infected, you leave it alone. If there's an issue, you saw with that last case, I didn't need to take the bulla down because it wasn't a problem. The problem was the false os into the maxillary sinuses and the concha bullosa obstructing, that right-sided nasal pathway. If you don't need to do something, don't. The only exception to that is with advanced eosinophilic disease. So to me, a middle meatal antrostomy is exactly that. You do the uncinectomy and you take out that horizontal portion of the uncinate and just stretch the natural os open if you don't need to do anything else.
Okay, yeah, thank you. I think Bonnie says that we should take a break, right?
I think right. We'll need to do it.
So may I have?
I'm gonna sign up and get this next patient on the table, and I'll leave you to answer any more questions, and then have a break, and we'll let you know when we're ready. Thanks, Conkia.
Okay, bye, Simon. Okay, who says that we should take a break? From the chat, huh? Okay. So guys, actually, we also have the participants in Bangkok. Any question from the floor from Thailand? Judging from your face, I see that I will ask you during the break. Okay, so let's have a 5 minutes break, and then after 5 minutes we'll come back. If Simon is not ready, we will continue the Q&A sessions. Okay, thank you.